You've had a bad week, maybe a bad 2 weeks. At a certain point, the line between normal situational stress and a serious medical condition starts to blur, leaving you stuck in a paralyzing loop of second-guessing yourself. Using the word depressed to describe a rough day at the office often minimizes the clinical reality of the disorder. This confusion frequently results in people attempting to manage severe medical conditions through sheer effort alone, while overlooking evidence-based treatment paths. Major depressive disorder functions as a measurable neurobiological condition that alters how the brain processes emotion and regulates baseline energy. To separate passing mood fluctuations from MDD, clinicians look for a strict timeline. The symptoms must be sustained continuously for at least 2 weeks to meet the diagnostic threshold. Clinical diagnosis centers on anhedonia, the chemical loss of interest in the activities, hobbies, and relationships that normally bring you joy. This table compares situational sadness against major depressive disorder. MDD brings heavy physical changes, like altered sleep, appetite fluctuations, and severe energy drops. By requiring anhedonia and psychomotor markers for 2 full weeks, the criteria isolate the disorder from temporary grief or stress. This chart illustrates the broader systemic impact. Untreated major depressive disorder causes an estimated $44 billion in lost productivity for U.S. employers every single year. Highly effective evidence-based treatments exist. However, the condition itself often drains the executive function and physical energy required to navigate the healthcare system to find them. Identifying the neurobiological symptoms is the first step. The next challenge is bridging the gap between clinical necessity and the logistical friction of actually securing care. Clinical care begins with an accurate professional diagnosis. While online quizzes offer a sense of validation, only a licensed clinician can legally and safely direct a treatment plan. A professional evaluation establishes the clinical foundation for targeted interventions, allowing a patient to begin behavioral activation therapy or integrate SSRI medications. Historically, seeking this evaluation meant navigating complex scheduling and commuting, tasks that become increasingly difficult when battling MDD-induced fatigue. This flowchart maps the pathways for someone whose symptoms have persisted for over 2 weeks. The 100% telehealth model, used by Georgia's Coping and Healing Counseling, serves as a low-friction alternative to traditional in-person care. The telehealth path provides immediate logistical benefits, including a 0-minute commute and the availability of same-week intake, which bypasses the physical travel barrier. Choosing this model involves inherent trade-offs. The therapist lacks full-body physical cues during the session, and the patient must guarantee a private, quiet space at home for the duration of the visit. To manage these cases remotely, a telehealth team requires licensed professionals, LCSWs, LPCs, or LMFTs, specifically trained in specialties like anxiety, trauma, and complex grief. This delivery model covers a broad population scope, serving individuals, couples, and families, including teenagers age 13 and older. A dedicated telehealth practice solves the physical energy barrier of the commute by shifting the responsibility of creating a secure clinical environment to the patient. Beyond physical logistics, financial barriers frequently prevent patients from initiating the therapy they need. This chart details the financial landscape of an in-network provider like Coping and Healing Counseling. Medicaid coverage results in a $0 copay, while commercial plans, including Aetna, Cigna, BCBS, United Healthcare, and Humana, typically require between $10 and $40 per session. These subsidized rates contrast sharply with standard out-of-network costs, where high out-of-pocket fees often make long-term care unsustainable. Accessing these specific financial benefits requires meeting a strict geographical condition. CHC's services and in-network rates are exclusively available to residents living within Georgia's 159 counties. Within this network, clinicians use evidence-based treatments like cognitive behavioral therapy and behavioral activation to help patients restructure the thought patterns associated with MDD. These behavioral therapies require a sustained patient effort and consistent homework between sessions to successfully achieve long-term clinical results. In cases where behavioral therapy alone is insufficient, the integration of SSRI or SNRI medications provides an additional evidence-based layer of treatment. Low-cost, high-yield treatment is more accessible than in the past, but its viability depends entirely on the geographical boundaries of a provider's network. Long-term recovery depends on aligning your clinical needs with your actual logistical constraints. This scorecard maps profiles against CHC's telehealth model. Georgia residents get a high fit score for low copays and zero travel. For HR leaders, same-week intake reclaims productivity. Out-of-state viewers are restricted by licensing, but should use this framework locally. The 100% telehealth model is not suitable for individuals who lack reliable internet access or a quiet, confidential space within their home. Patients experiencing high acuity symptoms require the observation and safety provided by in-person psychiatric care. Every treatment path, regardless of delivery method, begins with securing a licensed clinical diagnosis. The choice involves weighing the long-term, compounding cost of untreated depression against the momentary effort of initiating an intake. Major depressive disorder systematically drains the energy needed to seek support. Aligning your financial and geographical realities with a frictionless telehealth network turns that barrier into an actionable starting point.